Great. Welcome, everyone. My name is Julia Coleman, and I am really excited to co-host this AAST Virtual Grand Rounds with Jen Hartwell tonight. And tonight we're going to be talking about crucial communications, navigating the multidisciplinary team and the complex surrogate situations. This is actually a collaborative session that was put together by a variety of different committees: the Communications Committee, Geriatric Committee, Palliative Care, and Critical Care. So we're really excited for tonight. Before we launch into introducing the speakers and their topics, a couple housekeeping items. So each speaker will have 15 minutes to present, and after our three speakers, then we'll then have about 10 minutes for Q&A. The chat box will be open for Q&A, and Dr. Hartwell and I will take turns calling on people to help moderate the question and answer session. So you have opportunity for that at the end. Feel free to put them into the chat box throughout the session. Also, please make sure that you are muted. We don't have capabilities for raising your hands. If you do have questions, just shoot those in the chat box. And we will go ahead and get started. So I will introduce our first speaker, Dr. Gorman. She is an assistant professor of surgery in Weill Cornell Medicine's Division of Trauma, Burn, Acute and Critical Care Surgery. Dr. Gorman graduated cum laude from Dartmouth College and then received her medical degree from University of Texas Southwestern Medical School. She completed general surgery residency at NYU Langone and spent an additional year as a clinical research fellow. She then pursued fellowship training in surgical critical care and acute care at Rutgers, New Jersey Medical School, and is now board certified in general surgery and surgical critical care. I'm excited to hear from her tonight. And Dr. Hartwell is going to introduce our other two speakers.
Yep. Thank you, Dr. Coleman. We're also very lucky to have Dr. Joe Cuschieri, who is a professor of surgery and laboratory medicine at UCSF. He is the chief of surgery at the Zuckerberg San Francisco General Hospital and the vice chair of acute care surgery at UCSF. And he is the current chair of the critical care committee of the AAST. We're also very lucky to have Dr. Matt Cook, an associate professor at Oregon Health and Sciences University in Portland, and an associate program director in the general surgery residency program. He's a member of both the AAST and American College of Surgeons Palliative Care committees. So broad depth of knowledge from all of our panelists today. So thank you for joining us.
Thank you. Should I go ahead and get started and share my slides?
Sounds good. I will stop sharing my slides and you can go ahead and jump in.
Okay, let me actually, can you guys see the, which, are you seeing two screens or just the one?
I don't see one yet.
Oh, okay. Hold on one second. Okay, how about that? Are you seeing that?
Looks good.
Okay, great. All right, thanks for the introduction. Hi, everyone. I'm Elizabeth Gorman. I'm a acute care surgeon at Cornell. I'm also doing my mid-career palliative care fellowship currently at Mount Sinai, and I'm a member of the AAST Geriatrics Committee. So I was asked to speak about how to manage discordant surrogate decision makers and tips and tricks for those often difficult discussions. Okay, so I'm going to start with a case presentation that I'm going to come back to at the end. Patient AA is a 70-year-old female with history of high blood pressure who presents after an MVC. CT head shows an acute bleed with a shift. An EVD was placed. Unfortunately, there's worsening herniation on repeat scans. She has a really poor neurologic exam. She's not really doing much. Neurosurgery doesn't offer surgery because it seems futile. She's unmarried. She has 4 children. 2 of them are hopeful that she'll get through this, hopeful for a miracle. And then 2 of them want to proceed with comfort care. So I'll come back to this at the end, but I wanted to discuss, how we should approach these difficult situations as clinicians. So really the first step in these discussions is to try to ascertain if the patient has decisional capacity. In this case, it's pretty obvious that they didn't. They're intubated, had poor exam, but that's a good first step. We're all familiar with what capacity is, can be assessed by any physician. It can fluctuate over time. And the patient needs to basically demonstrate that they can explain the risk and benefits and demonstrate some logical connection between cause and effect. And if that is if it's deemed that the patient doesn't have capacity, that's when we start talking about surrogate decision makers. So that can be done either by advance directives. So this would be something that would be previously dictated by the patient. It can be dictated by default surrogate laws if there is no healthcare proxy. And then in some cases, there may be a guardian or conservatorship for the patient. This might be in cases where there's concerns for abuse by the healthcare proxy or the surrogates, or in cases of intellectual disability. So I'll go through all of these things in the next few slides, but this is kind of the framework for how to approach this. So when we talk about surrogate decision-making, there's two ethical principles that we need to uphold. And these are really dependent on whether or not the patient themselves, if their wishes are known or not known. So if their wishes are known, either by healthcare proxy or by family participating in the discussion, then the principle we usually go with is substituted judgment, which is essentially what would the patient want if they were able to participate in the discussion. If the patient wishes are not known, then we defer to what's called a best interest standard, which is what most people would generally decide for themselves under similar circumstances, which can be subjective, but should be, based on the amount of degree and pain and suffering that's associated with whatever the proposed intervention is versus the potential for benefit. So this is a surrogate order, and I'm listing this from New York State, which is where I work, but it does vary by state. But I'll just go through this here because I think most states have pretty similar orders. So number one would be, anyone who was previously designated by the patient to make decisions. So that's usually in the form of a healthcare proxy, or if they do have a guardian, that would be the first person we would turn to. So that healthcare proxy would trump all other decision makers. Failing that, then we go to the surrogate order, which is listed here. So that's a spouse, if they're not separated, if they're not divorced, or a domestic partner. The stipulation for domestic partner also varies by state, but in New York State, that counts as number two. An adult child after that, a parent, adult siblings, and then lastly, extended family and friends. And this one also varies by state. So, in general, if it is an emergency situation, there's usually two physicians that will consent for the patient, but that principle varies by hospital. So just a note on legal considerations, because as I said before, this really does vary by state, and I'm just listing the New York ones here. Some states don't even have surrogate consent laws, but most of them do. 44 states have them. In 2 states, in Colorado and Hawaii, there's consensus statutes that basically say that anyone who's reasonably available and quote unquote interested can come to a consensus about decision making for the patient. And that would kind of trump the surrogate order that I mentioned before. But in general, those that fall lower in the hierarchy can't overrule anyone above them unless they go through the court. And in 18 states, if there is a dispute among surrogates at the same level, i.e. like if there's adult children that are disagreeing, then there are laws that state that you can resolve the dispute by going with the majority of what the patient's family wants. So I want to talk briefly about advanced care planning because this can be very helpful in these situations. And it's something we all should be familiar with. So there's different forms of advanced care planning, which is, essentially the idea that the patient decides in advance what kind of medical decisions they want in case they were not able to participate. So the one that we're probably most familiar with is a healthcare proxy. There's also living will and MOLST, which is medical orders for life-sustaining treatment. And I'll go through each of these. So a healthcare proxy, at least in New York, is a form that is signed by the patient. They have to have capacity, importantly, in order to sign this. It does not require a lawyer, but it does require 2 witnesses, and it has to be 2 witnesses who are not the patient in the healthcare proxy. If they have this paperwork, then that really supersedes any sort of surrogate order. So that would be number 1 on the list of priorities that I mentioned before. A living will is a little bit different. So this does require the presence of a lawyer, and this is a legal document. This is often done as part of estate planning. And it outlines preferences for medical treatment, often in events in which the patient becomes incapacitated or they're in a vegetative state. That's the most common way I've seen this done, which may be helpful, but I think oftentimes it's not as helpful as we would wish, because there's, oftentimes it's not as black and white as, they're in a persistent vegetative state, and there's often a lot more gray area which would not be covered by this, but it can be helpful. The next one is a MOLST, which we're all probably also familiar with. This can be completed by any trained medical professional. This can be very detailed. It goes through code status. It includes preferences for nutrition, dialysis, and antibiotics. Most people who are residents in SNFs often have these, and they usually get renewed every 90 days. So all this to say that advanced care planning can be very helpful, but there actually is a large body of evidence that shows that it is not as helpful as we think at the end of life. This is a paper by a group out of Mount Sinai that shows that really there's not a lot of literature that shows it's actually helpful at end of life, and it doesn't make any difference in terms of likelihood of goal concordant care, nor does it improve patient quality of life. So why might that be? Treatment choices at end of life are often not as consistent or as logical as we would hope that they would be. And this is often, times of great distress for patients and families, and that can cause decisions that, we thought were gonna, decisions that were previously made to change over time, essentially. So I think, in general, it's not a bad idea to do advanced care planning. I think certainly healthcare proxies can be helpful, but perhaps they're not as useful as we think they are. So going back to the case and the topic, challenges in surrogate decision-making. So this might happen for a variety of reasons. There might be different cultural or religious beliefs among family members. The patient's preferences are often unclear, and that might happen especially in cases of young trauma patients that have some catastrophic injury that they weren't expecting. And as I mentioned before, this is often times of great family distress, and oftentimes, family members who can't choose what to do will go with the path of least resistance, which is life-prolonging measures. So what are some strategies that we can do as clinicians? I think first and foremost to try to, put the focus back on the patient, and that idea of substituted judgment and what would the patient want. And I think it's easy for family members to disagree on their own, beliefs, but to try to bring it back to the patient and what they would want, or to try to get a sense of that. It's also helpful to just be as curious as possible and to ask a lot of open-ended questions to try to get to the heart of why there is a disagreement. It's also helpful to explore family dynamics. Maybe they had a family member that was sick before in an ICU that required hospice, and maybe they had a bad experience with that. So it's helpful to explore that. And then if all else fails, it's also a good idea to try to get a sense as if there's a primary surrogate among the people that are disagreeing who's willing to make a decision based off of the majority. I think underlying all of this, it's really important to establish rapport with the patient's family and to try to build trust. So that can be achieved through, multiple family meetings and consistent messaging. And I think it's very important to act as objective as possible and to be a mediator in these situations. So just a note on mediation. This is from one of the medical ethics textbooks that I looked at in preparing for this talk on tips on how to approach these kind of charged situations. So mediation is the goal of mediation is to maximize the likelihood that a resolution will be reached in a way that's comfortable or tolerable for all parties involved. So what they offer is this acronym STATA, which I think is helpful. So the S is for sit down. So you're going to sit down with the families, often have multiple family meetings. T is tell me about. So you want to, again, try to get a sense of what the patient was like and what they would want in these situations. A for admire, so to try to give them affirming statements that, we see that you're advocating for the patient. D, you want to discuss diagnosis, be as honest as possible, try to present all the possible risks and benefits, and be honest with prognosis and what you think. And then lastly, asking what they would want, what the family member would want, and what we think would be in best interest. And really the goal of all these kind of difficult ethical situations rest on these core ethical principles, which we should all be familiar with, but just to go over again, party autonomy, which is the idea that the patient can decide what they want from themselves, not doing harm to the patient, and to try to be fair and equal. So a couple more strategies, I think giving consistent information is important, especially if there's a lot of teams involved. And especially when we're talking about prognosis, you want to make sure you're giving them consistent messaging. So what might be helpful before these family meetings is to have a pre-meeting with everyone involved and to make sure that what we're telling the patients is consistent and we're all on the same page. A time-limited trial is another potentially helpful thing. So that usually is, giving the patient's family a certain time limit, maybe a week or a couple days, to see if that makes a difference in the plan. So maybe for this lady, for example, saying, let's wait a week, let's see if there's any difference in her neuro exam. And at that point, if it's not any better, then we have more confidence that her prognosis will not improve. The other added benefit of this is it gives the family more time to process really difficult news, and so it can be really helpful. The family might request to get more information in the form of second opinion or more imaging. That can help guide the clinical situation. And, it goes without saying that an ethics consult can be very helpful in these situations. And getting the multidisciplinary team involved, the social worker, the chaplain if the patient's spiritual. And in general, I think in an emergent setting, when emotions are high, it's probably safest to go with the most life-prolonging option, at least initially. So going back to the case, and then I'll wrap it up. So we did get palliative care involved. We got ethics involved. We discussed kind of the two pathways, doing trach, PEG, LTAC versus comfort care. And I think what we did well in the situation is that multiple groups of clinicians gave patients consistently, we were consistent with saying that the prognosis was poor. The family requested an MRI, which we got, which also showed that the prognosis was poor. And then finally, after several more meetings, the family did agree on transition to comfort care and the patient passed. So I'm going to stop there because I think I'm over time, but I just want to give a special thanks to the ethics team at Cornell and the palliative care team at Sinai that I work with. So stop sharing.
Thank you so much, Dr. Gorman. I was taking notes and pictures during that. I really like that Stata tool. That's, I think, excellent. Let's move on to our next speaker. Feel free to share your screen, which is Dr. Cook.
Sounds wonderful. Give you a moment. Clicking buttons. Screen. Give me just a minute. I'll have things up for you. There we go. Hopefully you should all be looking at the main slide presentation.
Yep, we can see it.
So thank you all very much. And I was struck by one of the things Dr. Gorman said right at the end, where she mentioned that all the teams communicated effectively and gave one consistent, clear message, because that's actually what I am going to be focused on. And you'll notice that some of the visuals here were developed in collaboration with AI tools, and I use Undermine, which is an AI-supported research tool for the research synthesis. Yeah, I've got 15 minutes-ish, and here are my objectives. And really what I want to focus on is emphasizing one key take-home, right? And that key take-home point is what Dr. Gorman emphasized, which is this is our job. Our patients and our families deserve a single, unified message to be delivered with clarity and compassion. The ICU is obviously a very complex interpersonal and medical environment. Consulting physician teams, nurses, respiratory therapists, clinical pharmacists, and 100 other people who each have an opinion about what the right thing may or may not be to do, who interact with the patient and their family on a regular basis. Add in multiple levels of trainees, add in a bunch of advanced practice providers with varying degrees of experience, and the potential for unintended communication errors becomes clear. When you compound this with actual variations in opinion between attending providers and then by extension, their teams. And you can see how people get confused and distressed. So I'm going to submit, and this is the takeaway from my portion here. It is fundamentally our job as surgical intensivists and acute care surgeons to keep the message aligned. Our patients deserve it, and our colleagues deserve it. So this is just an imaginary example, but I'm sure we've all had variations of this. 7 a.m., you walk into the ICU, you clip your badge onto your soft shell, you put your Splenda, your coffee, everything's happy, and then you walk right into a mess. Critically ill patient, doesn't really matter the details, but they're intubated, hypotensive, 3 pressors, and there's 4 notes in the chart. The ICU resident wrote some variation of transition to comfort measures. The medical student on the surgical team wrote some variation of patient stable, improving overnight. And the PGY2 on the primary surgical team wrote some variation of needs a CT scan and then interventional radiology for source control. Patient's child's terrified. They think their parent is dying because they talk to the ICU resident. The spouse is optimistic. They think they just need a CAT scan and a trip to IR and things are going to be fine because they talk to the primary team's resident. And the nurses are furious because they see all of this. So you do a quick loop. You realize what people have been sort of unintentionally relaying. But really what you're dealing with is 1 patient, 2 teams, 3 different notes, and 4 or 5 more different opinions. So really what we're talking about here is prognostic discordance. And it is our job to make alignment of the prognosis and alignment of the communication the default, not the exception. So really this occurs when we deliver inconsistent, unclear, contradictory messages about the patient's outcome. It doesn't just confuse families, it actively undermines their trust, it impairs their decision quality, and it negatively impacts their emotional processing. Now, when I talk about unified team communication, improving outcomes, I'm not suggesting that this is going to improve your VAP rates or your surgical site infection rates or maybe might obliquely affect mortality rates, but that the patient-centered outcomes that we care about, family distress, lack of trust, decisional regret, goal concordant care, can be improved with improved communication and reduced prognostic discordance. Now, I acknowledge these are really difficult to measure. These are outcomes that are very difficult to measure. But that doesn't mean that they don't matter, because they clearly do. Also, navigating the discord that comes from prognostic discordance, the interpersonal discord that comes from prognostic discordance, affects your team. This has happened more times to me than I can count. I'm sure it's happened to you, where you arrive at the bedside and to a furious bedside nurse who's had to listen to 3 different physician teams, deliver 3 different messages to 3 different family members, and they just are beside themselves with the communication that we're providing. Now, this matters. It's ludicrously difficult to study. I was not able to find actually any studies that specifically address this. But in an immediate sense, this distress in our teams that comes from prognostic discordance, the amount of time and effort and emotional energy that we invest in fighting with each other, distracts from our ability to do our jobs, distracts from our ability to execute the plan, distracts the ability to think critically about patients' care. And in the long term, that's moral injury and burnout and attrition and one more drop in the bucket of the staffing crisis. Now, again, it's very multifactorial, very difficult to measure, but they matter. And our role as trauma surgeons, I'm going to keep coming back to this over and over and over again. Yes, it's clinical leadership. Yes, it's taking out spleens. Yes, it's putting people on ECMO, and it's also communication and stewardship. We are uniquely positioned as acute care surgeons, surgical intensivists, to align, translate, and unify these prognostic messages so the families hear a single voice and not 2 or 3 or 4. I mentioned this. Evidence is difficult to come by. It is really difficult to study. It is really difficult to do high quality studies on even when people decide to. This is from the European Society of Intensive Care Medicine, and it's not really directed at the goal at the question that I'm talking about right now, prognostic discordance. This is talking about end-of-life care. A lot of times these prognostic discordances do get framed near the end of life. A lot of end of life happens in the ICU, but these guidelines are specifically on end of life care. And the question is, who should manage high stakes communication in the ICU and how to mitigate conflict in the ICU between healthcare providers and their teams? And there's just not much out there. I think this conference report and expert panel came out in 2024, low level of evidence, insufficient level of evidence to allow for more recommendation. That's okay. Not everything needs to be guidelines. I love guidelines. They're fantastic. I kind of like writing guidelines, but I do believe that we can draw some conclusions from available data to make the inferences that we need to. The first is discordant prognosis is incredibly common. As much as we want to tell ourselves it's not, it is. I think this study gives us a window into that, into how families actually experience communication during critical illness. It's not trauma. It's not really even our ICU population. It's after spontaneous intracerebral hemorrhage, but I think the broad strokes are valid. It's a mixed method study. Qualitative. I'm going to focus on the qualitative outcomes here. 52 surrogate decision makers whose loved ones were hospitalized with an intracerebral hemorrhage, and they asked them how their physician teams or how their care teams communicated prognosis. And the result, 19% of them, 90% of surrogate decision makers got a discordant prognosis, 1 in 5. That means that despite our best efforts, 1 in 5 of our patients gets a discordant prognosis. Yes, I know this intracerebral hemorrhage is not trauma. Yes, I know this is not necessarily our institutions, all of those things, but that's still a lot. And it wasn't just confusing, it was consequential. 15% of the cases, discordance led to distress, fear, frustration. This is 15% of the total cases, not 15% of the 19%. And actually 6% of cases, 6% of the total cases led to a reversal in critical decisions, including withdrawal of consent for potentially life-saving surgery, or moving from withdrawing life-prolonged or life-sustaining treatment to an interventional surgery. So aligning prognosis matters. 5% of people, 6% of people, that actually directly impacts decision-making. And in a larger number, it leads to real harm, leads to fear, distress. And when we look at the quotes, and I highlighted the ones here that I want you to focus on, and I acknowledge that I'm selectively choosing the data that aligns with my point, I think these data matter because we hear the voices of the surrogates. This prognostic discordance led this person to believe their physicians were lying to them. And our profession is fundamentally built on trust. We ask people to trust us, to put our hands inside their body and rearrange their insides. We ask them to trust us that we know what we're doing. And when we give them discordant prognosis, they think we're lying to them. Another, again, you get 5 different opinions, 5 different people. It's overwhelming. And in this case, that overwhelming delivery of information that was discordant resulted in a significant change in the care plan. Patient who went to surgery instead of withdraw life-sustaining treatment. Now, these aren't rare. 1 in 5. 1 in 5 patients had significant prognostic discordance to the point where their surrogate decision makers remembered it. And this is why it's so important. 1 voice, 1 message, and 1 team, and it is our job to guide that. So I thought that this is a great figure from a paper by Vick et al. That kind of highlights why surrogates misunderstand what we're talking about. It shows that there's space between the clinician's estimate of the prognosis and a surrogate's perception of the prognosis. They hear something's different than we tell them. We know that. And also, there's a difference between what they hear us tell them and what they believe. So there's room for surrogate decision maker misunderstanding and for disagreement. Now, this is different enough, and this is a figure that is a feeling, not a figure that is a number. But there's even in the best case scenario, you've got a single clinician providing a single estimate, And the surrogate decision makers misunderstand what we're trying to tell them. Now you start adding in different clinician estimates from different clinician teams, and you can see how people get confused, lose trust, become distressed, and make things worse. So this is really where one voice, one message, one team becomes essential. It's our job. I know that I continue to put this up here over and over and over again, but that's because I want you to remember. So, and another, you may think, oh gosh, maybe if we're delivering this information, people think that we are not being compassionate. Oppenheim et al. Looked at this, and they think they know something that we intuitively know and occasionally say out loud. But I think that our junior learners and our colleagues who are not as seasoned in the ICU as we are frequently struggle with. And they struggle with clarity equaling compassion. And so they result, you're inexperienced in the ICU, either as a learner or as a clinician, you default to indirectness, euphemism, and abstraction when you're navigating critical illness, death, and complications. And we've all felt that, right? It just sort of sucks to go and tell somebody that their loved one is dying or has died or that a complication is happening. I don't like doing that. I have practiced doing it. I've thought about how to do it. I know it's important to do it. I understand the clarity. But if you don't do it all the time, it's easy to be put off and provide, and through euphemism or oblique wording or indirectness, give a discordant prognosis. But the data is clear. When we are vague, people don't understand us. When we hedge, they fill in the blanks, as outlined in that Vic et al. Image that I just showed, with hope. And when that hope is misaligned with reality, it leads to pain and confusion and distress, particularly when another team comes in and gives a clearer but much more pessimistic assessment. So I'm just going to emphasize the key finding from the study here, which is, and this was sort of a theoretical study. It took 300 participants, all of whom had family members with serious lung disease. They asked them to imagine they had their loved one in the ICU, not actually having the loved one in the ICU, and then they watched clinical vignettes of a physician providing prognosis. And the only difference was one group saw a physician responding directly to the prognosis, and it was poor prognosis. And the other one saw sort of vague, indirect, or hedging language. And the result, participants who listened to direct language had a much lower perceived chance of survival. And actually the difference there is gigantic. Sort of the difference between direct to physiological condition updates, and the sort of redirection, let's talk about something else. It's a huge difference in what the surrogate decision makers perceived as a patient's chance of survival. So why does this matter? Because if we are indirect, or if other team members of ours are indirect, not through malice, not through trying to sandbag us, but just from an uncomfortable, like just an inherent uncomfortableness delivering bad news, we will set ourselves up for patients wildly misunderstanding reality. So it's really about one voice, one message, one team, and it's our job to keep everything aligned. So we have to help our friends here. Many of our consultants and trainees simply haven't had the reps. They're not deliberately misleading people. They're falling prey to the tension we all feel when we have to deliver bad news. They're just less experienced at managing it. They hedge, they default, they allow room for that difference between the clinician estimate of survival and the surrogate's estimate of survival, and people fill that in with hope. And so families get whiplash because one team's overstating and one team may be understating or more realistically stating prognosis, and that leads to distrust and altered decision making. So how do you deal with it? Pre-plan your conversations. Don't let family meetings happen. Don't let even brief bedside updates just happen. Take 60 seconds, catch people before they go in the room, and make sure we're aligning the messages. It does take some effort, but that's what required. Name the prognosis, name the recommended next steps, and choose language together. That alignment matters. Use structured communication tools. The best case, worst case ICU model is fantastic. It allows everybody to have their input. provides a most likely scenario estimate. There are others. I do particularly like the best case, worst case one. It lets clinicians clarify their opinions. It gives us all a unified document to refer to. It allows us to talk directly to other faculty or senior level learners, and avoiding that U-shaped communication that can happen when you're communicating through junior residents. And it gives patients and their families a realistic assessment so they don't get whiplashed around. And then round together. This really matters. You don't need to have the entire surgical oncology team come on all of ICU rounds, but go to the bedside with them in the morning, especially in cases with prognostic uncertainty or when there's no discordance. Show face together, be in the room together, use the same language that builds the one voice message throughout the day and throughout the week. And clarity isn't just what we say, it's what we plan for. When our consultants feel supported rather than thrown into high stakes meetings solo, they're more likely to communicate clearly, consistently, and compassionately. So this is really our job. We shape the narrative and we align the teams. Patients and families experience our care as a single team. And whether or not we want to or we like it, we own that. Our job is to be in charge of the ICU team. Our job is to be the acute care surgeon that's coordinating things. It is our job to align these teams. We speak everybody's language: intensivist, surgeon, medicine, neurosurgery, palliative care. We speak everybody's language in a way that allows us to align. When we do this well, our teams will do it well. Our consultants rise to the occasion, and our residents and students internalize it. So, final takeaway: one voice, one message, one team. And this is our job, and it's how we show up for our patients. Thank you.
Thank you so much, Dr. Cook. I think you brought up so many great points. And I do think I talk about this concept of like radical and brave compassion, and that's sort of a theme throughout how we guide these discussions with patients. I just thought that was amazing. And then we'll lead the way here with our last speaker. So Dr. Cuschieri.
So thank you so much. I'm going to build on the conversation that we've had just a moment ago, just to further talk about the role that we as surgeons play and the critical role. Following on what Dr. Cook and Dr. Gorman said, this is really a critical aspect of what we do on a daily basis. Whether we know it or not, or whether we call it palliative care or not, we do this, we practice this every day. But one of the key things is, why does it really matter? Why do we as surgeons, why do we as intensivists really play this critical role? Well, we are there. We're there at this inflection point. We take care of patients at a catastrophic period of time. They come in acutely ill, injured, dying. We need to be there. We need to be understanding of the role that we play. And this is not over a period of a long time. This is over minutes, hours. This is not months, years in terms of the decision-making we are being confronted with. That is why we play such a critical role, because we are there. We are part of the process. But part of the process is we were, as Dr. Cook said, we are the ones operating on these patients. There is a significant amount of trust that's already placed in us because we have provided such a critical service, a trust that few of us get to experience. In addition to this trust aspect, we saw the pathology. We can explain it. And it is critical, similar to the one message just described, that we are very clear in terms of what we saw, what we did, and what we expect. Without that, families, patients expect what we have already done to rescue them, to allow them to survive. And it is really critical as we have these conversations early on that we are providing the appropriate narrative to this patient population, to their families, to their surrogates, so they clearly understand what the prognosis is, and we don't give them false hopes. Well, one of the key things, and I think it's really critical for us to explain, is that as surgeons, we provide palliative care on a daily basis. We are the primary palliative care service. We lead these discussions. It is important, as described and just mentioned, that we have a clear voice. Our whole team is on the same page. We are providing a consistent message. Now, there are times when we need secondary palliative care services. These are services that are provided, usually consultation, to really formalize some of the messages that we want to provide. And there are really reasons to have this. They are not mutually exclusive, though. We provide this together. We should be part of these discussions and work together with our consultants to ensure one clear message, as previously discussed. How do we accomplish this? Well, I think the important aspect of this is that we can't translate what we see by giving numbers, giving values. Telling a patient or their family or their surrogate, the lactate's 9.8, they don't understand that. So it is really critical that as we describe the conditions of patients, we use phrases that they understand. For example, if the patient is doing poorly, has multiple organ failure, that we describe that we are doing everything, but despite our best efforts, there's ongoing evidence that the organs are failing and we are unable to potentially rescue them. This is critical that we do this early. We do it with compassion and empathy. The framing is important. Again, having this one clear message, not to have false hope, is really critical to the aspects of what we do. This clarity actually helps families, surrogates, and patients themselves have appropriate goal-oriented care. So when do we need our specialists? When do we need our palliative care services? Well, there are critical reasons to have these. And amongst them is really to deal with disagreements between us and the family members. As we see things and prognoses that are not compatible with long-term survival, it is really critical when the family is unable to understand that, disagrees with us, to have other individuals involved in this care. Disagreements occur amongst family members themselves, and these are sometimes very difficult to navigate. It is critical as healthcare providers and directly involved in the patient care that we are part of the discussions, but these are areas where we may need additional expertise to help navigate these difficult conversations. Additional times is when there's an inability to make decisions, when we can't move forward, when there's an inability for us, despite our best efforts, to describe what is occurring, where there's paralysis in terms of the ongoing movement forward to have palliative care services involved. And then with longer term aspects, with ongoing evidence of delirium, long-term pain management, movement from the acute ICU care to comfort measures, to even further hospice care, where pain and pain management is critically needed. And then there are times, and I think we need to think of ourselves as well, where we have moral distress, where we are unable to clearly and accurately define what is occurring and is affecting us. And that is a time to actually get additional help and additional resources. Again, I want to state very clearly, I think well done by both Dr. Gorman and Dr. Cook, the use of palliative care does not mean we're giving up. We are just changing our mode of management of a patient, moving away from being aggressive in terms of the medical management, but providing goal-oriented care. Timing with this is absolutely important. As I stated in the beginning, this occurs in a very rapid fashion. We are dealing with patients who have rapid deterioration. We do not want to wait till we're at the end. We don't want to wait till we have maximal vasopressor support. This is why having a clear message early on regarding the prognostication of patients, what we are seeing, what we are doing early on, to clearly reframe and have the patient, their family, and their surrogates understand what is occurring so they can make appropriate decisions and goal-oriented care. Their values need to be taken into consideration. It is impossible to feel and to be able to do this in this chaotic environment without clear messaging, the one message as previously stated. As a result, early communication, continuing to have these communications is really critical. The patients, their families, their surrogates then realize we didn't give up on this. We are just changing the mode of care that we are providing, and we are actually honoring and supporting the family as well as the patient. Palliative care and adds significant components to what we do, and this is why we do need them. They provide help with the family. They can narrate and frame things in a different method rather than us being personally involved. And they obviously play a critical role in the continuity of the care that occurs outside of our surgical ICUs, especially patients who will be discharged to longer term care facilities and hospice care. But we have to own part of this decision-making. This change in terms of how we reflect and manage patients is partly our role. It is essential that we are constantly involved because this is a continuity of care that needs to be provided. We own this. We have to realize we are critical to these decision makings. We provide the first conversations, the first meaning, the first narrative to the situations that are occurring. We need to understand what the prognostication is and how we prognose these patients and what we think is going to occur to provide one clear message. Once we have this clear message with consultation with other providers, other team members, palliative care services, we have a sustained, ongoing message. We don't change that message, we're consistent. If new data comes about, we provide that new data still with goal-oriented focus in terms of the patient. The East Palliative Care Guidelines, which Dr. Cook brought up, a different set of guidelines, really do reflect in terms of how palliative care services reflect and how they are managed. We, as surgeons, we as intensivists, provide that primary palliative care service. We are discussing these patients. We are discussing the situation with the family, their surrogates. It is important as we consider this, we work together when we have difficulties in terms of the conversations with palliative care services within our institutions to provide a uniformed, goal-oriented message. As we continue to work with them, there are times when we may change that message as we move from an acute phase to a long-term phase where palliative care and specialty palliative care may be dealing with the long-term effects of the decision makings that were performed early. But again, as we transition through these various phases and different models, we still play a critical role in all these discussions. How do we know that we've actually had an impact? Well, if we do this correctly, if we provide a clear narrative, if we have these discussions early with one clear message, we can reach an understanding of what the code status should be of a patient earlier. We can neglect and not have non-beneficial OR trips where we know rescue is not going to occur. And the families can, once again, to us, articulate what is important to them, what is important to the patient, and what is important to the outcome. Families who experience this, experience and report that they've had a peaceful, understanding, non-abandoning declaration of ongoing care. It is critical as we continue this discussion. I look forward to the questions here in a moment, that we provide a simple, clear message at all times, that we take the time, as previously stated by Dr. Cook, in regards to having one clear message to the family members, that palliative care services are important when we have disagreements, to allow us all to work together to have this one consistent message. This is not a competition with our other palliative care services or those who study this in more depth than some of us did. This is us working together, providing the best care and a goal-oriented measure. Thank you.
All right, thank you so much to our panelists. Dr. Coleman, unfortunately, is having some technical difficulties, so I'll go ahead and round us out. These talks have been truly amazing. I really appreciate the insight that you all have brought to us. Additionally, this type of content is just ripe to be collated together into a white paper or something that can be distributed more widely. So thank you again. I'd like to open it up to all of our participants if they have any questions that they would like to answer. In the interest of time, and we do have a relatively small group on, you can go ahead and unmute. Hopefully you'll be able to unmute and ask a question. If not, you're welcome to drop it in the chat. And while we're waiting for anyone to answer or to ask any questions, I did have one question for the panelists. Do you have any advice about how to manage when there's discordance between the patient and family and the care providers, when patients and families want to just keep going and going and going, and the care team feels that the care is approaching futility, but the family is quite engaged? What suggestions do you have to provide advice to the care team in that situation?
Oof, that's a tough one. Um, it, the other one that's actually really hard for me, I feel like we've got much more experience in that one. The one that's really hard for me is when I think a problem is fixable, right? Like the brain injury is not that bad, or the sepsis can be treatable, and the family's like, "Nah, I don't think they want any of this." And I'm like, "Oh, well, we can get them. Like, we can get them through. They're a fighter." And you know, the advice that I got once and that I continue to apply and I give to my trainees is a lot of times that's a misunderstanding of values. So when you find yourself really at odds or misaligned with family, usually the right answer is to stop trying to make decisions and start trying to understand values, because there's oftentimes a value or the cultural frame or something that you don't understand that will allow you to better understand that. And then, at the end of the day, like, yes, I may disagree with that decision making. It's not what I would have made for my loved one or for myself, or what would be made for me. But if that's what the patient's wishes would have been, and it's not like, frankly insane, probably should have phrased that better. And like it's completely outside the realm of reason. There is some wiggle room for that there, and I think that's okay. And it's uncomfortable less, and that's what it gets to Dr. Cuschieri's point. It's at some point, like, our job becomes make sure we're aligned with the patient's goals, and then support our team as they sort of struggle through this potentially injurious period for them.
Yeah, just to piggyback on that, I think that was so well said, but I think, there sometimes can be a lot of moral distress, especially from the people that are taking care of the patients, whether that be the nurses or, the medical team, when what they think is right for the patient is at odds with what the family wants. But if it's not unreasonable, then that's one thing. If it actually seems goal concordant that we do whatever the patient would have wanted or what the family wants, I think that's reasonable. I mean, if it's not reasonable, I think that's when you start getting ethics and stuff like that involved. But yeah, I think I agree with Dr. Cook, trying to get a sense of what the family's hoping for and what they're worried about. Are they hoping that they're going to leave the hospital? Like, do they have realistic expectations, or, are they just hoping that a miracle will happen? So it's really important to get a sense of what they're thinking.
If I can just follow up, I think we tend to talk more than listen. And I think one of the key things is during this is actually listening, really trying to understand, as was just said, is have the family members talk about what they see, what they expect, because this is our opportunity again to add some clarity to this, and to say what is actually possible and what is not possible. And I think it's the ongoing single message, again, being very clear that everybody's speaking the same component that we need to do. Again, just because you can does not mean you should. And I think it's very clear that we need to be able to have clear conversations, but understanding where the family is coming from and what their expectations are really critical to this. This is the one area where palliative care services, if you have them in your institution, can actually help. Because this coordinating care, we get emotional, we get defensive. And I think we have to understand that defensive behavior only worsens the entire situation rather than making it stronger and better. So having that one collegial use, and having those conversations, but listening to the family, I think is one of the critical things we tend not to do.
Yeah, that's such great advice. I'm gonna, in the interest of time, because we did start a minute or two late, but also I want to respect everyone's time. I know some of us have other commitments, but I'd like to take just 2 minutes to go ahead and answer one of the questions in the chat. I think this is a great question that we've all been involved in this situation. Tiana Spencer asked, what advice will you give for situations when there's a family member in medicine who clouds the care decisions, particularly when they are a nurse or a pharmacist or a therapist or otherwise not specialized in the patient's pathology, but are very vocal in the decision making? Very delicate situation. Any last minute advice as we round out our panel today? Lots of loaded questions.
Yeah. Joe, you want to go first?
Sure, I bring them into the conversation. I think I allow them to talk and speak about what their concerns are. The family is going to look at them as the expert in their group. And I think it is a conversation, but having them understand and reflect and talk about what they know, what they see, and then helping them navigate what they may misunderstand. And I think it takes time. It's a lot of more work, but I think it's incredible work that needs to be done early. And you don't want to do this late. I think one of the key things is these discussions, if you see this happening, is having these conversations very early on and having an understanding who they are and where they're coming from.
Yeah, I think I was going to say something very similar, and I've actually had them when I do that pre-meeting or pre-briefing with the consulting services, have them contribute to the best case, worst case scenario map, right? Like when we're mapping it out, because they're gonna the last thing you want is to say something different than that trusted family member or relation is going to say, because they're going to believe them, not you. And then you will become a liar. And then you've lost all of the alignment that you could have with that family.
And even if it's not a family member, this is going to be more and more difficult on all of us because access on the internet allows people to come and tell you what should be happening. So I think we need to realize this is part of our practice, and we need to be aware of this and take the time to have these conversations, which take more time than before.
All right. Such great advice from all of you. Thank you so much for leading this expert panel. In the interest of time, I am going to go ahead and wrap things up. I know other folks have commitments at this hour. So thank you very much to all the participants for joining. We apologize for some technical difficulties in getting started a couple of minutes late. So thanks for your patience. And we really appreciate your participation. Thank you so much.